You want to take advantage, beatable discounts and everyday low prices and a full range of back-to-school essentials all in one place at your Naivas Kiloko. We're getting back into school. We've done it for the last couple of days. And we've also seen the experiences through which Naivas has walked with us. And we'll walk through this with you again as we get back into school. We know that you'll be topping up that shopping. So don't worry about how far your shopping basket can be stretched. Ki jaze, ki kapu, ki bonge with Naivas. And let's make this season a breeze as you turn into the hero they see you as you walk with them every step of the educational journey. Do it this season with Naivas. We have a Healthy Friday conversation as we normally do Fridays. And today we're going to look at one issue that has bothered many a woman. And by virtue of the fact that it has bothered many a woman, it has also bothered many a family and many a community. And we're looking at the issue of fibroids. And even as I mentioned it, you already know what it has done. But there's a ray of hope in treating fibroids in Kenya. And to have that conversation with us this morning is Dr. Kireki, who's been with us before. He is the president of the Kenya Obstetrical and Gynaecological Society and joins us in the hot seat this morning. Daktari, good morning.
Good morning. Good morning.
How are you?
I'm well.
Yeah, Karibu Sana. It's always good when a doctor says they're well. Because we know we're in good stead, isn't it? So we're going to be looking at what has been a sticky, thorny issue for many women and many families in terms of to surgery or not to surgery and how you're going to treat it. But what is the ray of hope for many women who've gone under the knife and still have issues? And we'll look at the causes and we'll look at the treatments and we'll look at, this ray of hope, essentially. But before we get into that conversation, CT will tell you what country he's in this week, and he'll share today's proverb with you. And you can do the beauty of interpretation for us, right?
That's all right.
Okay.
We are in the People's Democratic Republic of Algeria. Mm-hmm. Yes, a lovely, lovely, lovely African country. The proverb, a sensible enemy is better than a narrow-minded friend.
A sensible enemy is better than a narrow-minded friend.
Yes.
Now, that's a difficult one, CT, for me. It's this morning to end the week. But I think if you have a sensible enemy, I think you can be able to talk to this enemy if you have issues, as opposed to the very narrow-minded friend whom you may not be able to come to terms with anything. So I think it is possible, and as they say, you leave your doors open with enemies, because enemies can also be friends turned inside out. That's the way I'm looking at it. So if you have a sensible enemy, you have a chance of maybe striking a deal, as opposed to a narrow-minded friend.
Well put.
Absolutely. That's it. I love it. And even as we jump into our conversation this morning, we're looking at fibroids, treatment in Kenya, and looking at a ray of hope. But by the time we talk of a ray of hope, that means that there's been long suffering.
Absolutely.
For women. Let's start off with definitions. When we talk about fibroids, what are they, and how do they present?
Thank you. First of all, thank you very much for inviting me to the studio. It's always a pleasure to come here and talk about women issues, and women issues we know are central to the health of a country. And I think, again, when you look at our Constitution, Article 43, it says that every person, every Kenyan has a right to quality healthcare, and especially reproductive health. So reproductive health, women's health is central to our development and our quality of life generally. So when you talk about fibroids are basically it's a benign growth, or they are benign growths. And these growths are on the uterus, on the fibrous muscle of the uterus. There are different types of fibroids depending on the location. They are what we call intramural fibroids. Just as the name suggests, they are in the muscle of the womb. They are what we call subserosal fibroids. And the serosa is basically the covering of the uterus. And if fibroids grow just beneath the serosa, they are called subserosal fibroids. Sometimes these fibroids will go and they will have a stem, sort of. And these ones we call pedunculated fibroids. And we can also have what is called submucosal fibroids. And what is that? Basically, if I would say that, if I look at my hand, that this is the uterus, anything that grows inside the what you call the cavity, and the cavity is where a baby grows. So anything that grows there is called a submucosal fibroid. Sometimes the intramural fibroids may grow to such an extent that they will sort of poke into the cavity, and they'll be called submucosal fibroids. You can also have what you call cervical fibroids as well. And these ones grow, there may be two types. They may grow on the cervix, and the cervix is basically the entrance into the uterus.
Yeah.
Or they can also be pedunculated, meaning they grow inside the cavity, they have a long stem, and they appear on the cervix. Now, fibroids are very interesting. It's a very interesting pathology. If you look at the epidemiology, that is how often they occur, it is one of the most common issues affecting women. Depending on which researcher we look at, it is estimated that anywhere between 20, others say 60, even up to 70% of women, especially women of African origin, it doesn't matter where they are, whether they are in Cuba, whether they are in Colombia, whether they are in Africa, whether they are in the US, will have fibroids during their reproductive periods.
70% of all women
in the reproductive periods.
Oh, wow.
In the reproductive period. And normally we look at the reproductive period from anywhere between 18, 19 years to around 40, 45 years. Now, it has also been noted that women of African origin, the number of fibroids that they have and the sizes, the number is more, and the sizes are a lot bigger as compared to other races, as it were. Just as one of my colleagues actually wrote a paper, he wrote a case report, and the title was quite enigmatic. He said, "Mine are 140. What about yours?" Basically, what he was saying is that he had removed 140 fibroids from a patient, and he managed to retain the uterus. So this is a problem, and we see a lot of women who come to us because of fibroids. They've had a lot of issues, and yeah, one of the biggest problems that we have with women in this reproductive age is fibroids, and also it is one of the most done, if I can say, the most type of surgery that is done is one of the most common.
Wow. So, I mean, we talk about it being so prevalent, and we know but what is the cause of these fibroids? What causes this growth, benign as it were? What causes it?
We are not very clear about what the cause is. When we have looked at the fibroids and taken them and analyzed them under microscope, and then tried to find out what are the receptors, because there was a hypothesis, there are different hypotheses that possibly they are they are caused by hormones. And what was found out is that the female hormone called estrogen, and this is the hormone that makes women be women, in the sense that they have bigger breasts, they have wider hips, they have a smoother skin, and so on and so forth, actually is contributory to the growth of fibroids. But why exactly, it is not very clear, because these fibroids, when analyzed, they are found to have more receptors of estrogen than the other hormone, which is called progesterone. So we are not very clear about what the reason is. However, there is anecdotal evidence whereby the fibroids run in families. You say, oh, my mother had fibroids, my auntie had fibroids, and so on. But do we have a genetic cause per se that says that this sort of pathology runs in families? No, we don't have something like that as yet.
Okay.
Are we saying, therefore, that women of African descent
Yes.
have more estrogen than other women who are not of African descent? If, speaking anecdotally, this is one of the causes.
Thank you. I think that is a way we haven't looked at it, but it is possible because when you look at quite a number of African women, you find they are bigger, they are rounder, as it were.
The word is voluptuous.
Yes, voluminous. Good. as compared to other women. So yes, there is such a possibility.
That's interesting.
Yes.
Let's make the connection.
Yeah, African women tend to have more ample proportions. That we have understood. But then whenever a discussion of this nature is had,
Yes.
and you're through with the hereditary aspect of it, people always talk about diet.
Diet, yes.
And what is that people are accustomed to eating. Would this play a part?
It could play a part because one of the causes that it could be contributory to the presence of fibroids is diet, and then of course the obesity, that is also part of it. But is there cause effect, as it were? Not necessarily, but it is one of the things that we think that could be one of the reasons.
If we don't see on a balancing scale,
Yes.
we seem to know less than we know more. So then how do we treat it? I mean, we are saying that this is a condition that is prevalent,
Yes.
but we manage or treat it with this little knowledge that we have. My question is this: why do we have little knowledge on the subject?
Because of several things, I think. First of all, when you look at, when you try to find out the real reason for this, we actually haven't found out the reason. We thought maybe, okay, because they have more receptors, estrogen receptors, so can we reduce the estrogen such that these receptors are fewer? You can't reduce estrogen in the body because estrogen is basically the hallmark of a patient, of a woman, for that matter. In terms of diet, there has been some work which has been done, and there are some certain elements which have been found in some foods, and these foods are more prevalent, are more used by Africans. But does that mean that the food that we eat here is the same food that is eaten in the US, for example, or in Colombia, for that matter, or in other places where we have women of African origin? Not necessarily. So, in as much as we think that, yes, there could be an element of, diet, but we don't exactly know which of these elements is actually contributory to this.
So, Doc, you've mentioned something to do with the genetics and the way it could be through the family lineage,
Yes.
as could be a possibility, of course. So, with that information being then, perhaps your patients or women understand that. Are we seeing more women taking charge in terms of their daughters going to hospital earlier, just to arrest it earlier to start treatment?
You see, when we talk about a genetic cause, is that we have to isolate that this is the gene that actually controls this disease. For example, we know there are genetic diseases like sickle cell anemia.
Yes.
We know what causes it, and it will control this, and so on. We know hemophilia, for example, and there is a gene which has been isolated, and this is across the board. Wherever a patient has hemophilia, this gene has been isolated. When it comes to fibroids, we actually don't have that at the moment. That is number one. And then number two, these are incidental findings. When you're taking the history, and a patient comes and said, have you in your family said, yes, actually my mother had surgery because of fibroids, or I have also an auntie who had surgery because of fibroids, and it ends there. Now, in order for us to say that, yes, there is a gene which is actually driving this, it has to be across the board. So you find there are others who have a mother, a sister, an auntie who had fibroids, and others are just isolated cases. It's just one of them who has fibroids.
Right.
So that is why we can't actually say that there is a genetic factor per se.
Unless a woman or a young woman, older either way, had gone for a screening,
Yes.
would I be correct in saying that most discovery of fibroids is when there is something wrong, that there is a symptom that would then lead you to check why? Is that the case?
Actually, yes.
Okay.
A lot of in a lot of the cases, the fibroids are asymptomatic. They don't have any symptoms at all. And by the time a patient comes and starts giving you her story, most of the time you have a 70 to 80% chance that actually this patient is actually having fibroids. And what are some of these symptoms? First of all, the patient will come and say, I've been having, when you're taking the history, one of the questions that we ask is, how are your periods? It's a basic, one of the first questions that we ask. My periods are regular. They come after every 28, 30 days or whatever it is, and they take long. How long? They take 7 days, some of them 10 days. That is already a red flag. How heavy are they? Oh, they are very heavy. What do you mean by that? And of course, what we want to find out, how many pads do you use? He said, Daktari, I use a pack of pads in a day, and sometimes I need an extra napkin, for example, in order for the periods not to overflow and, mess my undergarment. That is also another red flag. And then number 3, they say, and how are the periods themselves? Apart from them being heavy and taking long, they have clots. That is also another red flag. And then apart from that, because of the heavy loss of blood, you find these patients complain about feeling weak, feeling dizzy, feeling lethargic, and so on. So by the time we get all this information, we are almost sure that what we're dealing with is fibroids. And then when we ask them to lie down on the couch and we examine the abdomen, most of the time you see this is an obvious mass. The uterus is big. Sometimes it's reaching where, let's say, what we call 20 out of 40, because we normally measure the size of the uterus and compare it to pregnancy. So we can say the size of the uterus is equivalent to about 20 weeks of pregnancy. It's equivalent to about 26 weeks of pregnancy, and so on. And we have had patients who actually have been congratulated by their colleagues. They say, congratulations, when is the big day? But they don't know that actually these patients are having, huge fibroids, and they look as if they are going to deliver, in a week's time or in 2 weeks' time. And in the meantime, they have a huge problem, with fibroids.
But Doc, wouldn't you know that there was something amiss by the time? Because when you're 20 weeks pregnant, you're 20 weeks pregnant. You will feel it.
Yes.
And in this case, there's something in your midriff, and you're not pregnant. By the time it has gotten to that size, you would have known that there was something wrong, no?
Actually, yes and no.
Okay.
Some patients will say, I've been having this thing for some time. Then we ask them, how long have you had this problem? He said, I've maybe 5 years. And they said, 5 years, you never noticed? Say, I thought it would go away. That sort of thing. And have you ever noticed anything hard? Someone he said, yeah, but I thought those maybe are the intestines or something like that. So sometimes, yes, these patients know there is a problem, and others either know and they are in denial. They don't want to accept that there's a problem. And there's a patient I had who unfortunately had fibroids for about 7-8 years, and when she came to see me, when you looked at her, you'd think that she's 38 weeks pregnant, meaning she's almost going to deliver any time. And then it got so complicated that she had, because of the size of the fibroids, they pressed on other organs in the body. She ended up having clots in the vessels, what we call DVT, and it almost killed her. And then apart from that, she was pregnant. So a very, very difficult patient to manage. So yes, sometimes these patients have an idea, and sometimes they are in denial. Sometimes they don't know.
Then again, at times women go through this, because I've been around a relative who had fibroids, and when they asked, it was dismissed as kawaida, mambo ya wanawake itaisha. You know, it is dismissed like that, and one assumes that when 1, 2, 3 women that you know tell you about that, you relax and say others have gone through it and it's okay. How does that information or such advice affect one seeking treatment?
I think that is very important. Ladies, as opposed to men, ladies are very social. Ladies will meet and they'll discuss anything and everything. They will meet in my reception area and they will start talking. They'll ask questions. They'll ask each other questions, you know, quietly. And after that, you know, they'll even form a WhatsApp group, you know, a support group, sort of. And unfortunately, sometimes this can be very good because then the sharing of information is easy, but it can also be sometimes disruptive because if you are sharing wrong information, then it will affect the health-seeking behavior. It's unfortunate that that relative of yours was dismissed. I don't know, was she dismissed by doctors or by her friends?
It's like you say, they formed a group where they were just having this conversation, and information she was given was wrong until that time when she was in extreme pain. Again, she was as well expectant. So when went now to an OBGYN, is when now it was found the complications and treatment now began.
So that can be very positive, the talking and sharing of information, but I hope it is positive, good information, you know, accurate information, instead of saying, Ata, my auntie also had something similar, or my cousin also had something similar, na ilisha, and it was okay, whereby it's not proper information.
So, there are some myths. So debunk some of those for us. And one of the ones that we've heard quite often, and some of those coming in actually questions, is that if you have not had children as a woman, then the likelihood in that childbearing age that you speak of, 18 to 45, that if you had not had children or you've not been pregnant, that the chances of fibroids then presenting is higher. Is that true or not?
It is true.
Okay.
Because when you look at the reproductive cycle, by the time you get to around 13, 14, that is when ladies start having their first periods, meaning now what we call the HPO axis is actually active. But usually in the first few years, it can be a bit unstable. So when we get now to maturity around that 18, 19 years is when the periods become regular and so on. So this is a time now when, as we said, most of these women have these fibroids. When it comes to later on, after 40, after 45, most of these women have the estrogen levels have started, you know, sort of coming down. When they get to 48, 50s there, perimenopause kicks in, and then later on menopause kicks in. So the estrogen levels drop drastically. Even if they had huge fibroids, these fibroids will slowly shrink with time, and they will not be a problem. So yes, it is a quasi myth, but it is also true in a way.
Does it mean that if a woman has had a child before, the possibility of them developing fibroids then is close to zero? Or is that another myth?
No, that's a myth again. No. Yes.
Okay. Sometimes women have been told that when they do present with fibroids, they've gone for, examination. The advice of the doctor is to just leave them alone, and that there's no need to go in and remove them. Under what conditions would that advice be given?
Thank you for that. It's a very important question. As I said, most of the time these fibroids are asymptomatic. A patient will come and you ask her, say when you touch the abdomen and you examine her, you find, have you ever noticed anything? You say, no, I've never noticed anything. Do you have any problems when you go to the toilet, for example? You have what you call pressure syndrome, pressure symptoms, sorry. When you go for a short call, you feel as if you've emptied your bladder, but after a few minutes you want to run back and continue. Say, no, I don't feel anything. What about when you go for a long call? Do you have any pressure symptoms as well? You say, no. During intercourse, do you have any problems? You say, no, I don't have any problems at all. So the fibroids are there. It is an incidental finding, and they are not affecting her in any way. So there is no point of taking this patient to theatre, because you are going to remove them, and then what if they are not affecting the patient? We should take these patients to theatre when there is an issue. There's very heavy bleeding, there are pressure symptoms, and sometimes they want to have a baby because fibroids themselves can be a reason for infertility, and a patient has been trying to have to get pregnant a year, 2 years, or even more, and they have fibroids 5, 6, 7, 10 centimeters, and this can be a reason for infertility. Then this is when we take them to theatre for the removal of these fibroids, in order to also help them to have these babies later on.
All right, let's take a break at this point. It's a Healthy Friday conversation today, and we're looking at treating fibroids in Kenya and looking at a ray of hope. We're going to come back from the break and look at that ray of hope. Dr. Kireki Omanwa is here with us in the hot seat, and we're looking into many of these issues this morning, and then also trying to find out, well, is there possibility of other treatments apart from going under the knife? And that's a big one for a lot. We'll come back and continue with that at 28 minutes to 8. We'll be back.
Nairobi.
At 24 minutes to 8 o'clock on the Situation Room. Healthy Friday at this hour. We are looking into a beckoning array of hope with Dr. Kireki Omanwa. And we are looking at fibroids, the cases that very, very many women and many families go through. Is surgery always the solution towards this? We've heard many things, herbal remedies, take something to shrink the size and then you could eventually pass them out, things like that. Treatment options, what are those?
Thank you. Quite a number of treatment options. And the treatment options will depend on, number one, the patient. It will depend on the symptoms. It will depend on the sizes of the fibroids and on the location. There are instances where we don't do anything. We say, yes, there are fibroids. They are not affecting you. Your periods are regular. You don't need to do anything. Let's observe them every 6 months or so. Do a scan and see whether the size has increased, and then maybe review the options on the table. There are conservative methods of treatment. So, for example, the patient just complains about heavy periods, clotty periods, and then you notice that the fibroid is a small submucosal fibroid. You can actually use what you call an intrauterine contraceptive device, which has a hormone, and this hormone is released every day, small amount of hormone, which works on the lining of the womb, and sometimes it leads to a decrease in that size of a small submucosal fibroid. If the patient has the big fibroids and she wants us to conserve the uterus, then there are surgical options. Even before we go there, if the patient doesn't want to have surgery done, but she has serious symptoms, there are other medical methods of managing this. We can give her what you call hematinics, that is blood boosters, as it were. If she is experiencing pain, we can give her painkillers, analgesics, and we can also use contraceptive methods. Combined oral contraceptive pills can also help, especially with the heavy periods and so on. Now, if these methods fail and we have tried everything, you say, look, we think that another approach could be better, and then we can consider surgical methods. The most common surgical method that all of us who are obstetricians and gynecologists are trained in is what we call laparotomy. That is cutting open the abdomen. We cut through the several layers of tissue. We get to the fibroid, and then we slice it off, as it were, and suture the place where the fibroids were. This, every obstetrician and gynecologist can be able to do that. The other option is what you call laparoscopic surgery. What does that basically mean? This is basically minimal invasive surgery, where we make small incisions on the abdomen, maybe 3 or 4 of them, and we go in with instruments, and as we are operating, we are actually watching what we are doing on a screen. Not everybody is able to do this because it requires extra training, and the learning curve can also be quite steep, but it is available in Kenya. We have another method which is also invasive, and that is what we call uterine artery embolization, whereby we work with other doctors, other specialists, and we go through one of the vessels in the thigh, and they block blood supply through the uterine artery. The uterine artery is the main blood supplier to the uterus, and the idea is once that blood supply has been blocked, the uterus will actually shrink because it will not have any blood going to it, and with time it will shrink. Now, the other methods which have been propagated, and we actually see them out there, is using herbal medication. I'm not against herbal medication, but the only problem with herbal medication is that, number one, we do not know what is in this herbal medication. We do not know the chemical composition. We do not know how it works, and we do not know the strength of what this herbal medication is. For example, they'll tell you, take this kibuyu and every day drink 1 cup or 1 glass of it. But cups and glasses are not equal in terms of capacity. So we actually not very sure how it works. And then we do not have enough evidence looking at it scientifically, whereby X number of women were treated with this herbal medicine compared to Y number of women who had something different or who had a placebo. And then of course we measure the sizes of these fibroids before the treatment, and and progressively, let's say after 3 months, 6 months, 1 year, and we have a control sort of study, and then we see if in X the fibroids actually shrunk or even disappeared as compared to Y, then of course we can recommend this herbal medication. Unfortunately, we don't have these kinds of studies at all. Even though, of course, ladies, as you said, ladies pass on information. I took this herbal medication and it really helped. It shrunk my fibroids and etc. Then we have something new which is in the market, and that is a non-invasive procedure, which is called HIFU. HIFU is basically high-intensity focused ultrasound. Ultrasound can be used for diagnostic purposes. For example, ultrasound, these are waves. And when you say ultra, it means it's high frequency. And they are, I may not be very clear about the physics of it. These waves are harnessed. And for example, if you're expectant or if you have some issues with your abdomen, you go to a doctor, you go to a radiologist, and they will, sometimes they'll ask you to drink a lot of water for the women, and they will take an instrument and put it on your abdomen and see what is happening with the womb or with the pelvis for that matter, or even with the abdomen itself. These, they are not radioactive. So ultrasound is used for diagnosis, and it can also be harnessed and used for treatment. In this case, when you're talking about fibroids, instead, when you're using it for diagnosis, the waves are actually dispersed, as it were, before they get to the target organ, and then they are reflected back to this the instrument, the equipment, which takes these waves back and forms them through the physics and mathematics. It creates an image which we can actually see on a screen, and we can be able to diagnose what is happening. Now, in HIFU, it's the other way around. These waves, instead of them being dispersed, they're actually focused. If you can imagine, when we used to use a magnifying, is it a or focusing, was it called a magnifying glass? Magnifying glass. So the waves from the sun are actually focused to a certain point, and if you put a pepper under it, because of that focus, it actually burns it. So the idea, simplistically, is basically the same, that the ultrasound waves are actually focused, and as they are focused, they create energy, very high energy, heat, which is anywhere between 60 to 100 degrees Celsius, and this energy now can actually be focused on the fibroids, wherever they are, and they are burned or they are ablated.
Do we have this treatment in Kenya?
Actually, yes, it is available. It is available. And I must say that Kenya has joined the elite group, as it were, because we have very few of these machines in Africa. The first machine was in Egypt, in Cairo. And then I think South Africa was number 2. Nigeria has 2 of them. Good morning, Do.
Yes, please. Thank you.
And then Tanzania has also one, and Kenya has one.
What are the likely chances that even after this treatment, the fibroids can recur?
Thank you. A very important question. Usually, when we go in and open the abdomen and remove these fibroids surgically, or even when we remove them, through laparoscopy, there are some micro or macro cells or tissues that we leave there. And unfortunately, we warn the patient that there is a possibility of these fibroids recurring, but we cannot tell when and how fast that can be. And we see patients who, after surgery, they come after 2 years, as if the fibroids are back. But the vast majority of them, they don't come back. Now, when we talk about HIFU, remember, it is using energy and it is burning the tissue. So the chances of them recurring is a lot less than if you're going to open.
Since you're talking about chances, what then does one do if one wants to seek a solution that offers permanency? Is it possible?
Yes and no. Yes, in the sense that it depends on what you want. If you want to get rid of the fibroids completely and you'll have no problems at all with the periods and so on, then the best option would be to remove the womb. Then that is permanent.
That's what you call hysterectomy.
Hysterectomy. But if you want to have a baby, if you want to carry yourself, because you can have a baby through somebody else, if you want to carry the baby yourself, then obviously that is not an option. But this new method, I think, offers a better chance of them not recurring. It doesn't mean that it reduces them completely to zero, but remember that we are burning this tissue as opposed to surgery where we are removing, and the chances of leaving some tissue there, which later on, under the influence of estrogen, will grow again, is a lot higher.
Okay.
You've mentioned something to do with 70% of African women highly likely to have fibroids.
Yes.
Then we come to the issue of data in the country, if that is there.
Yes.
And if at all the country is having a conversation, bearing in fact the 70%, having a conversation on policies around treatment of fibroids in the country.
Correct. I'll look at it in 2 ways.
Yes.
Are we having a direct conversation about how we deal with fibroids and what we are doing directly? Not really, because I think sometimes when you look at let me put it in terms of priority.
Yes.
Let me put it that way. When you look at, for example, the number of women who are dying because of bleeding during pregnancy or just after delivery, it's a bigger pressing problem than the fibroids. And remember, quite a good percentage of these women who have fibroids are actually asymptomatic as compared to these emergencies which we have to deal with. So I think the conversation, the fulcrum is more towards how do we stop these women from dying, and the children as well, the newborns, as opposed to how do we solve this issue of a large percentage of women having asymptomatic fibroids. So I think when you put that on a balance, I think the scales are tipped towards solving these emergencies than looking at the fibroids.
By and large, we are informed that fibroids are non-cancerous.
Yes, even though
Thank
even
you.
though
I can see you're going to answer what I was going to ask. So please continue.
Even though a very small percentage, according to literature, is say about 0.1 to 0.4% can actually be cancerous. Then how do we then say these ones can be cancerous and these ones are, strictly benign, as it were? The history is very important and it is cardinal when it comes to us thinking about this. When a patient comes and says, I've had something is growing here, and it started small, and then after a month, from that maybe 2-3 centimeters, it's going to 10 centimeters in a very short period of time, then we are highly suspicious that this can actually be what you call a sarcoma, which can happen from fibroids. But by and large, most of them, 99 point something percent, are benign.
Okay. Is there a link between contraception that's used, which is hormonal based, and the prevalence of fibroids? Is there a connection between the two?
There's no cause effect, as it were.
Okay.
Because I remember, as I said, one of the methods of treatment is actually using combined oral contraceptive pills. So there is no connection that if you use contraceptive pills, then you are going to have fibroids.
Okay.
No.
Okay, so we're seeing a lot of questions coming in from folks who are tuned in, and I guess we can go through some of them because I think it's important to do.
Yes.
One of those questions is the herbal medication, of which you've kind of gone through, and that there are folks who are swearing by it, that you can use herbal medication and you find that the fibroids don't really bother you, or they can shrink in size, along those lines. Is it so? Has it gone through the proper channels in terms of then guidelines and standardization to say that you can actually use this, number one? And can you get it over the counter, or must you have gone through the diagnosing process?
I think that is a very important question, because when you look at some of the medications, or even a large percentage of the medications that we use are actually originally were plant-based. When you look at quinine, for example, even when you look at most of the medications that we use for chemotherapy, originally the origin is herbs or plants, for that matter. But what we are saying is, even though they were from herbs, they went through rigorous testing. We found out what is actually this element which is active, and then how does it act, where does it act, and what is the mechanism of action that actually leads to stopping, for example, stopping malaria, or stopping even a headache, for example. When you look at paracetamol, you look at aspirin, and so on. I'm not negating that herbal medication does not work. I'm not negating that. But what we are saying is that, yes, in as much as this herbal medication does work, do we know exactly what is in this herbal medication? Have we identified the chemical component that actually makes it work? And if we have identified it, what is the mechanism of action? For example, if you take most of the time, you take medication, they say this medication, it's best absorbed if you use it orally, if you use as an injection, or if you use it subcutaneously. Why? Because it has been studied and it has been noted that this is the best method of transport, number one. Number two, when it gets to the body, where does it go to?
Right.
How does it get to the target organ? And when it gets to the target organ, what particular protein or whatever it is does it affect, such that once you use it, it will actually alleviate the problem that we are trying to solve? We don't have this information. So in as much as, yes, I have nothing against herbal medication, but we do not have detailed scientific information which can actually help us and say, today if you're going to take 1 cup, and then we have to quantify what type of cup. Is it 150 milliliters, or is it 200 milliliters? That sort of thing. So if you take 100 milliliters of this, it has an equivalent of X milligrams, and this will work in this way. So before we get that data, it is difficult to say that yes, this we can actually prescribe this, as you get a prescription, or you can actually buy it over the counter.
Okay.
But I'm not saying that herbal medication doesn't work. We need rigorous data, and we need to find out the mechanism of action and the point of actions.
Okay.
Perhaps that should be a national conversation that the government should pick up, because then again, it is what many also consider to be part of the solution.
Absolutely.
But as we talk about that, treating fibroids is key, especially when it comes to early detection and intervention, to be able to deal with that. So how should we push that information? Because then again, one would still stick on what they're being told, or wait until that point where they are in extreme pain that they come to see doctors. How do we change that such that they seek assistance early enough?
I think that is health-seeking behavior. Normally, I don't know whether it's only Kenyans, but we rarely go to the doctor for regular checkups. If I are Africans,
Male African.
male Africans, especially. I mean, we take our cars to the garage, and over the weekend they have to be polished and they look sharp and whatever. But when we talk about now, can you please go and have your blood checked? Can you have your prostate, checked? And it is a no. It's a no-go area. So when you talk about so when you talk about now, how do we now start, diagnosing these fibroids early enough? It comes back to health-seeking behavior. We should have our checkups, once every year, once every 2 years. Even for example with cervical cancer, it's the same thing. Women don't come for their regular annual checkups even after 2-3 years, and so on. And the effect is what we have. So health-seeking behavior, I think here is basic.
So a situation, a woman has fibroids, those have been established, not ready to go under the knife, and she gets pregnant.
Yes.
So baby and fibroid operating in the same space.
Tricky, quite tricky.
But it has happened.
It does happen.
What would you say?
Number one, we need to follow up this patient very, very carefully, because remember, during pregnancy, the body produces a lot of estrogen. And remember, we talked about estrogen being the quote-unquote the feeder or the food of fibroids. That is number one. Number two, as the baby is in the womb, there's a lot of blood which flows into the womb, and the fibroid will also take advantage of that, and they will grow exponentially. So this baby and the fibroid or fibroids will grow. Normally during pregnancy, we don't do anything about the fibroids, because if you were to touch that fibroid, most probably you'd leave that patient on the table because of the excessive bleeding that would occur. So we leave, as the Bible say, the wheat and the tares will grow together until judgment day, as it were. So when the delivery time comes, that is when we need to make a decision. Because if these fibroids are big, or if it's a big fibroid, it will affect the mechanism of contraction of the uterus. So it may be difficult for this patient to deliver naturally.
Yes.
So we have to think and plan how to deliver her by cesarean section. And then even during the cesarean section, we also have to have a plan B or even a plan C. Say, for example, if this fibroid is actually where we are supposed to cut, what are we going to do?
Yes.
So we have to have a plan B. Do we cut, vertically instead of transverse, and so on? So these are the things which we have to deal with. But this patient has to be taken very good care of. That is number one. Number two, remember again, as the fibroid and the baby are growing, the uterus is expanding very rapidly. It may reach a place whereby the uterus starts contracting prematurely because of the fibroid. So again, medications which will try to quieten the uterus in order for it not to start, contracting prematurely. And once we have delivered her, rule of thumb is not to touch the fibroid during cesarean section. However, sometimes you may remove it if it has a stem and is pedunculated, and it is safe for the patient. We can actually remove it, but rule of thumb is don't touch until delivery. Then we reassess once the patient has recovered.
So final question for you, Doc, this morning is that, it's one that has plagued many a woman over time, but are you now as medical practitioners, obs and gynae, now comfortable with the treatment, with the management, of fibroids now. We don't know what causes it, so you can't get rid of it from that aspect.
Yes.
They're going to happen so long as there's estrogen.
Yes.
We can't do anything about that because
Yes.
it comes with the package, right?
Yes.
But are you saying that now we're living in a space where we can handle or manage?
Exactly so. We have quite a lot of options on the table, starting from conservative, medications. We have, hormones which we can use. We have operative, surgeries which we can do. And then, of course, we have now this new kid on the block, which is non-invasive. You have, it is done in one day and the patient goes home very comfortable in the sense that the patient doesn't have to go to theater, doesn't have to have anesthesia per se, that one of deep anesthesia. And that the issue that the comfort about this is that the patient can go home in the evening, go back to her family and so on. And the recovery period is also shorter and so on and so forth. So yes, we are comfortable. Now, something which I want to underline here is that not all the patients will be, will qualify for all the methods.
Yeah.
There are patients who will qualify for this method, and other patients will qualify for
others,
other method. That is number one. Number two, the issue of insurance comes in, and also the issue of the economic side of things. How are we going to pay for this? That also does play a huge role, and I think here the insurance companies and SHA also can come on board and help these patients to help us to help them, as it were.
Always good to get insights and to go deeper into some of these things as opposed to just hearing them surface level. Good for us to share this information.
Absolutely.
And we're glad that you've done so brilliantly. Thank you very much. Dr. Kireki Omanwa is the president of the Kenya Obstetrical and Gynaecological Society, has been with us this morning, giving a ray of hope towards the issue of fibroids. Thank you so much.
Thank you very much for inviting me to the studio.
Good morning. 8:01.
Unveiling Kenya.